So welcome everybody to this very special interview for our class, Global Maternal Health, Cultural Perceptions and Policy Solutions. So in this course, we're trying to explore the perspectives from different players in the health system, including mothers, healthcare providers, and policymakers. So today we're going to focus on nurse midwives, and in the jargon of global health policy, these are called skilled birth attendants, and we have a case study from Peru. Now, we're so fortunate to have as our guest today, Professor Lucia Guerra-Rayes, who is author of the article, Implementing a Culturally Appropriate Birthing Policy, Ethnographic Evidence of the Experiences of Skilled Birth Attendants in Peru. Now, Professor Lucia Guerra-Rayes is Associate Professor in the School of Public Health at Indiana University, Bloomington. She's a medical anthropologist and interdisciplinary researcher. She started her education in her home country of Peru, and then she completed her MPH and her PhD in anthropology at the University of Pittsburgh. So Lucia and I regularly meet at national anthropology conferences, and it's always a delight to catch up with her. And I'd also like to introduce Erika Barton, who is an undergraduate senior in our BS in public health. And I think Erika has a few questions for you, Lucia.
Thank you, Dr.
Sounds great.
Magrath.
Great to meet you both. Great to see you, Pricilla.
Great to meet you. I read your article. I really enjoyed it. I do have a few questions regarding it that I'd be interested in asking you, if you don't mind.
Yes.
So my first question is, I want to know how you first became interested in learning about birthing policies, and did you already have a background in it?
So when I was an undergraduate anthropology major in Peru, I chanced on a conference. I went to a conference, and at this conference, there was a passing remark for one of the people that did a presentation who said, Indigenous women don't go to the clinic. And that kind of stuck with me, because as a 20-something-year-old, as a almost 20-year-old, I think at that time, I thought, well, that doesn't make sense. Why is that? And that's kind of what launched me into this. And so as an undergraduate, I pursued that as part of my research project that we needed to do to finalize our career training as anthropologists in Peru. And so I went and I did some data collection in a northern region of Peru to try to understand birth care decision-making and try to understand. And basically, I talked to women and I asked them to tell me the stories of their last birth. And I found that a lot of the reasons that, and really many did not go to the clinic, the ones that did go to the clinic were women who did not have family members who could attend them at the time of birth, or whose partners were sort of outside of the town, so they were working in immigrant issues, or like had immigrated, or who had been taken to the clinic because they had complications, right? And at the time, and I'm talking late 90s, at the time the issue was very much in part an issue of money, like going to the clinic costs money. And also an issue of mistreatment and cultural misunderstanding, right? And so all of the things that I talk about I did as my dissertation research that then became my book, Changing Birth in the Andes, was something that came up as a cultural issue, right? The idea of different perceptions of health and body. Yes. So different perceptions of health and body, different perspectives or preferences for what women perceived as a good birth. All of that sort of was in buds in initial, when I did that kind of research in 97.
Wow, that's very interesting. That's very cool. In your article, you talked about Peru's intercultural birthing policy. What is that exactly? And could you give a brief summary about it?
Sure. So in the intervening years between 1997, when I did this research as an undergraduate, and 2005, when I applied for my 2004 or 5, when I applied to the PhD program, several policy changes had happened that were affecting or were designed to affect maternal health in Peru. And one of them, sort of like they started looking at all of the issues. And so there was a universal maternal health insurance that came on. So then money theoretically was no longer an issue. There was an expansion of the public health system, especially for primary care facilities. And so theoretically, you could reach a primary health facility. So access in terms of geographic access was not an issue. And so the last thing was something that in Peruvian circles, they called the cultural barriers, which is what I had seen when women tell me that this is not the good birth that I wanted when they were like when I was an undergraduate. And so it turns out that in those years, UNICEF had also done something similar. So they had seen that there were some clinics in parts of the Andes where there were a lot of in-clinic births, and there were others that there were not. And so what they did was go to these places and ask the midwives, the nurse midwives, what's going on? And what they found was that there were some places where the nurse midwives were more attuned to the cultural expectations of the population. And therefore, women felt more comfortable going to the clinic, and they had higher levels of care. And some of them collaborated directly with traditional midwives. But they kind of did this on the sly, right? It was like, I'm up here in the remote area of the Andes, nobody's gonna come check on me. Like, I'm just doing this. And they kind of went rogue. And what UNICEF did then was like, okay, let's make a pilot out of this. And so what they launched a pilot in 5 areas of Peru. The pilot was successful. The pilot was basically what became the policy, which is they mandated some changes, physical changes in the care practices. So they changed the birth care protocol. So instead of women being disrobed and washed and shaved when they came to the clinic, they were allowed to keep their own clothes. They washed themselves with warm water. They were allowed to have herbs or hot herbs with them. They were allowed to have family members during labor and delivery, whereas in regular protocol, that is not allowed in the public health system, sometimes during labor, but never during delivery. And then there was the whole issue of delivery in a warm environment, delivery with vertical birthing positions being allowed. So there are really horror stories before that of women being tied down so that they birth lying down, which we know is not a physiological way to birth. And so UNICEF did all these pilots and sort of sketched out this kind of policy in their pilots, and they had successful pilots, and that is what became the policy, right? And they called the policy intercultural birthing with vertical birthing with intercultural adaptations. So the policy document puts a lot of emphasis on the vertical birth rather than the culture part. And that was a strategic decision because vertical birth and physiological forms of birth were very well documented by the medical literature in the global north, and they could use that as leverage with OBGYNs and the Ministry of Health, whereas culture is kind of tacked on, right? But in the shorthand, it became known as the intercultural birthing policy.
So that's interesting that they were using the evidence-based medicine card to get this policy through. But I do remember from your book reading that they developed slogans, you know, that this just like giving birth at home,
yes,
or something like that.
So once the policy was was in effect. It was not a compulsory policy, it's one of these soft policies, so it's not like everybody has to do it, but it was areas that had very high levels of maternal deaths. This was in the context of the country trying to reach Millennium Development Goals. And so it was a very fertile space in terms of policy for new things to be tried out. And so the way that they marketed it was, you can give birth with us like in your house. You can birth with us like you're at home, because they changed the spaces to be more home-like, as in Andean home, like Andean birth care, but with a skilled birth attendant, which in this case, in Peru's case, is the nurse midwife.
Thank you for that. That was very interesting. Based on your article, I noticed that the National Skilled Birthing Attendant curriculum does not provide any training on those central aspects of the intercultural birthing policy, such as you had said, vertical birthing, humoral theory, and active support person role. Why do you think that is?
So I think that there's a kind of a lapse, a time lapse, right? So I think that there was interest in applying these new birth care policy, or these new birth care forms in the Andes, especially in areas that had high maternal mortality, because they had been proven that it would get people to come to the clinic. But of course, the people who were there in the clinic were people who had been trained 5, 6, 10 years before. Therefore, that was not the form of birthing that they were trained in. Now, like I'm talking, it's been 10 years or more already. There are more courses on intercultural birthing or culture and birth. Nevertheless, there's still a lot of resistance, especially from the OBs. So in Peru, there's as in many countries, there's sort of a clash between who owns birth, right, in the clinic. Is it the OBs that own birth in the clinic, or is it the nurse midwives? Traditionally, in the public health system, it's been the nurse midwives, because there are no OBs in the rural Andes. However, there are OBs in the cities and in the regional cities. And so in the regional cities, the people that teach birth care protocols are very resistant to teaching intercultural birthing, because they see it as going back to tradition and undeveloped, and it's of less prestige. And therefore, the nurse midwives who learned it in doing it, when I was doing my research for my dissertation, some of them were feeling like they were ostracized from their peers in their profession, because they had learned this thing which was more like traditional birth attendants, and not these high technological, highly medicalized things which people who stayed in the city did. And those were more valued in terms of career currency.
So if more training was included, and do you think it could lead to a change in attitudes towards Indigenous births within the medical profession?
That is the hope. However, I will say that there's a couple of things that sort of thread through all of this. And one is an issue of class, race, ethnicity, and the relative status of Indigenous knowledge versus biomedical knowledge, which is kind of reflected in this idea that learning about medical things related to birth is better than learning about Indigenous things related to birth. So that is part of the issue. But also in Peru, much of the medical personnel who goes to work in rural clinics is not of Indigenous descent. And not only are they not of Indigenous descent, because being Indigenous has been vilified and stigmatized for a long time, a lot of people who go on to professions and sort of leave their more subsistence farming parents, for example, go to the cities and study, seek to emulate whiteness or the whiteness adjacent culture, which privileges biomedicine over traditional and more women-centered forms of care. And so there's a real resistance to all of that also requires, on the one side, I think, a really wholesale support for the validity of traditional forms of care for cases that, you know, are normal births, for example, and that are non-complicated births, as we have in some places in Europe, for example, where the midwife is where you go. And also more of a change in social perspective in terms of what knowledge matters, right? And this is where decolonializing medicine and the health professions is a really important thing to do, to be able to recognize other knowledges.
Do you believe there is any evidence that the intercultural birthing policy actually improves the quality of maternal care and patient satisfaction?
So, yes and no. The no part is, with much chagrin, when I did my dissertation research, I was very much looking forward to seeing this policy in action, right? So, but when I did, what I found was that there was this sort of superstructure in the people who were implementing the project, which was numbers matter more than what people experience. And so some of the policy was implemented, in its implementation was coercive and relatively violent towards people's rights, right? So they would force women to come to the clinic. They prohibited all traditional midwives to be in contact with anybody who was in birth, right? So you couldn't go to the traditional midwife, even though the traditional midwife still remained in town or in the community. They were sort of prohibited from doing any kind of birth care under sort of, they were told, you know, if you do this, I will denounce you. It's prohibited. And there were all these ways in which nurse midwives tried to coerce women to come to the clinic for birth. And the following sort of punishments for those that did not comply in coming to the clinic for birth. And so in at least one of the sites where I did my research, I did research in 2 sites, the community was not really aware of this policy as a good thing, because the coercion and the abuses of the medical professionals to come to the clinic were so strong that is all that the community saw. And the reason for that is because they were under a lot of pressure to reduce maternal deaths. And there's a persistence of thought that is, if we can get Indigenous women into the clinic, then we reduce maternal deaths. And that is true, right? If you can get people who are very much at risk for death into a clinic, the likelihood that they are not going to die is higher. So in that sense, maternal deaths were reduced. But at the same time, this was not a intercultural affair in that sense. So a lot of what I describe in my book, and that is somewhat foreshadowed in the article where the midwives say, I wasn't trained for this, or, you know, I'm between a rock and a hard place here. A lot of that was very difficult to watch and very violent. and very, very negative in terms of trying to get this policy done. And in the end, I mean, and this is something that the one of the top people in the Ministry of Health, in the end, what mattered for the Ministry of Health and what mattered for those clinics was not culturally appropriate care. So that was not the goal, right? The goal was reducing maternal deaths. And so there's another article that I put out there somewhere, which is called, it's only the numbers that matter, because that is what they were thinking about. It's only the numbers. So in a sense, it kind of tainted the policy because it became a way to sort of cajole women and sort of push them towards the clinic with claims that may or may not be true, depending on whoever is there giving the care, right? So there were some nurse midwives who were very, very attuned, very nice, very whatever. But if that person leaves, you have somebody who just goes through the motions, or you have somebody who doesn't do vertical birth because they don't believe in it. And so a lot of the issues that I had finding sites was because nobody knew if they were still in effect, because they were like, oh, yes, so-and-so used to do that. Is she still at that clinic? Oh no, she left. So nobody does that there anymore. And so it really didn't feel like it was a cohesive and well-supported change in terms of culturally appropriate care.
So it really depended on who the personnel were at the clinic. So I think this is so fascinating, the way you're describing this, because in week 5, we're looking at the right to health and how that can come into tension with the evidence-based approaches. And we have an article by Catherine Storeng and Dominique Behag, and they argue that the focus on the evidence-based advocacy approach in maternal health policy has led to a narrowing of the goals, whereas it used to be with the Safe Motherhood Initiative, you know, when it was first launched in 1987 and the following decades, it was about women's health, basically. And now it's been reduced to just improving the statistics on maternal deaths. And so from what you're saying, this is an example of that process of the sort of narrowing, which is just seems so very unfortunate. That
yeah, and I definitely agree. And in the 1980s, what they did in Peru was there was this that happened was the Safe Motherhood Initiative with many others. They partnered with the traditional midwives, and they had a robust referral and counter referral systems. So the midwives in the rural communities, the traditional midwives, would say, you know, just treat normal births, whereas they would sort of refer women to the clinic when they saw that they were not normal births. And when I talk to women about, you know, what they would want for care, they would want something like that. Like, I can do this birth, or if the nurse wants, she can come to my house. There was a lot of discussion in some of the interviews with the women about what happens when you go to the clinic, and I think we all experience this when you lose power, right? There's the whole issue of who owns the space makes the decisions, and women did not feel respected in their ability to make decisions in this space. So,
just to add a question about the parteras now. I mean, how do you see the future? Because what I've noted in global health policy is that there is a little bit of a shift back towards recognizing traditional birth attendants as a resource, and rather than excluding them, trying to give them a role in the health service. Do you see any of that happening in Peru?
I think so. And Peru is a different case. I mean, in Latin America, Ecuador and Bolivia sort of put intercultural birthing into their constitutions. Peru did not do that. And this afforded or has afforded over the years, and I'm talking around 2005, 2007, this has afforded some measure of validity to traditional knowledge. However, this is very much a politically contested issue because the same sort of racism and discrimination, anti-Indigenous discrimination that happens in Peru also happens in Ecuador and Bolivia. It just so happens that they had Indigenous, broad-based Indigenous communities that led to certain people to the presidency, which did not happen in Peru. So you need a fair amount of political support to keep on pushing for a recognition of traditional knowledges and ancestral knowledges as valid knowledges in care. And there have been, and I think that there's been sort of a mixture of collaboration with medical providers in terms of birth care from the traditional midwives to make this happen, like to become resources, and also a certain amount of agency on the part of the women and the traditional midwives, which I saw in Peru, to go to the clinic as birth companions, because there's so much turnaround on the clinical personnel that the parteras go as an aunt or as a cousin and sort of function, and I call this function as intercultural brokers, because they know the clinic and they know what the women want. And so they will say, you do this now, don't shout, don't flail, don't do this, don't do that, let them talk and I'll get you through this, so that they're able to negotiate in this sort of space of encounter. And I think that, I don't think traditional midwives are going to go away. And I'm hopeful that they will find these spaces of intercultural brokership. And I'm also hopeful that some of the economic booms that we are seeing, hopefully in Latin America, will lead to more people who are of Indigenous descent to move into these medical professions, because I think that is, as in the United States, an important and necessary step for the recognition of these knowledges and the needs as valid rights in the context of reproductive justice, right? So,
well, that's fascinating. Did you have any more questions, Erika?
Yes. So going off what you said about staff and personnel, I noticed that several of the skilled birth attendants that you had interviewed were on short-term contracts or possibly plan to leave the intercultural birthing policy clinics. Does this jeopardize the future of the policy?
Yes. So
terms.
So yeah, I mean and they were also, and if you look at the hierarchy of the clinic and the hierarchy of the health system overall, they were also among not the most excluded, because they were professional people. Like a professional in Peru, I mean, they underwent like 5 years of a professional school and studied and had certifications, but a lot of them were women, a lot of them were single, and a lot of them were young. And this was their first or their second post. And they did not see themselves keep staying in sort of making a life in rural Peru, because they were not rural people, right? They were not people who were descended from people who lived in that area. They did not feel comfortable in that space. And so their aspirations were aspirations to leave. And the healthcare system had these short contracts that they hired a bunch of people under these very short contracts, which also meant that if you have a 3-month or a 6-month contract, you are permanently trying to figure out, what am I going to do for the next 6 months, right? Or the next 3 months. And so that is no way to really connect with the people that you are living and serving, because your eye is perpetually moving outside of the space where you are. And that has to do with issues of compensation, of respect, right? Being in the rural areas was not as respected as teaching, as working in a clinic, for example. So if you put your CV forward and you have 2 CVs, and this person worked as a nurse in a clinic, and this person worked as a nurse in a rural area, this person is going to look better for whoever is hiring. And so there are all these sort of attendant issues around that. And also just and this is not particularly in Peru, but there's an inherent misogyny in the hierarchical nature of the clinic, right? Where doctors who are mostly male sort of look towards those who are more indirectly in service and therefore in contact with bodily fluids and people as less than those who have more removed care from the people. And so in Peru, you will see like most of the medical doctors are men. Midwifery is 98% female. And even the some sort of sprinkling of male identified midwives or nurse midwives don't generally work in patient care. They generally work in administration. So that has been my experience doing research in Peru for many years, is when you're like, oh, this is this guy who is a nurse midwife. And you say, oh, and what clinic are you working at? And they're like, no, I'm staff, I'm administration, I'm doing this. Because the direct work with people is sort of looked down on. And so there's all these sort of layers of gender and class and others that are sort of in that space, making it much more difficult for these women to imagine what they see for themselves, what they want, like middle class life, have a partner, have a child, and they don't see that happening in these rural areas.
But you did mention one of the midwives you interviewed was Indigenous.
Yeah.
You want to elaborate on that a little bit?
Yeah, this was for pure luck. And there was one Indigenous midwife, and she was the only one who was not outside looking. And that's why I think I saw that difference and why I'm thinking the things I'm thinking now. Because she grew up in an Indigenous language speaking household. So she spoke Quechua fluently. Her aunt was a nurse and also a traditional midwife. So she kind of was a nurse, but was also the person that on the lowdown cared for women in their community. And she used to go with her aunt to do these things. And that's how she became interested in midwifery. And it was very clear that her treatment and her rapport and her plans for the future were all much more congruent to working with rural populations in rural areas. Her main issue, though, was that all her supervisors and others did not valued other characteristics. And so, yeah, and I found her as a person really interesting, and I could see sometimes, because I hung out at the clinic a lot and sort of hung out with them, and I could see her sometimes kind of try to retreat from the group of the non-Indigenous midwives. Like, so for example, if the group went out drinking, she'd be like, no, I'm staying and I'm sitting with my landlady and we're going to knit today. So she did try to, but on the other hand, if she didn't participate in some of these coercive practices, that would not have looked good for her. Like it would have been like she would have a demerit or something, right? So she would not be looked as an equal. And so there was a lot of tension. And I often wonder where she's at and what she's doing.
That's great. Well, we've taken up a lot of your time, but did you have one more question you wanted to ask?
Yeah. Let's see. You mentioned pateras. I believe, are still popular. What role do they play in the intercultural birthing policy, if any?
So parteras, which are the traditional lay midwives, officially play no role in the intercultural birthing policy now. Way back in the day, or at the beginning of implementations, the nurse midwives in a clinic would call parteras to a meeting because there was an already existing, because of the Safe Motherhood Initiative, there was an existing relationship with parteras. A lot of the parteras participated in training. So the clinic had a training on asepsia or had a training on nutrition, and they would invite all the people who they saw as important people in the communities. And of course, one of those important people, like a leader person, and a woman leader is always the partera, because they're also not only sort of birth care, but generally just family care, right? So they take care of these minor ailments. If you are feeling kind of ill and you don't know what is going on, you go to the curiosa or the partera, and you're like, yeah, this is what's going on. What should I do? And she'll be like, oh, take this tea and do this thing. And so they were already relationships that were established with the parteras, and they came to the clinic for these meetings to talk about what women in the area preferred for birth. And these, the sort of the sharing of their knowledge was then what was used to implement the policy in specific clinics. So the idea of the policy is that you adapt care to the needs of the local population. And to understand the needs of the local population, what many clinics did was call parteras to meet with nurse midwives to talk about what those needs were. However, once that happened, they were like, okay, thank you very much. You cannot attend births. We are not doing any more trainings on hygiene or whatever, but we are happy for you to be community health workers and just help us figure out who is pregnant, who's not pregnant. Some of them were sort of the people that headed the mamawasis, the maternal waiting houses, where some women were taken from farther away rural areas so that they could be nearer the clinic. But many of them basically disengaged. I personally talked to about 5 of these traditional birth attendants. Or 4, but they still were the person who people came to for, this is what's aching me while I'm pregnant, and also when I'm not pregnant. So for teas, for these sort of more medical issues, they were still people going to them to get to sort of make sure that the baby was growing well, which is this idea of the manteo, or with the hands, where you sort of make the baby stay in one position so that it grows head down, so you don't have to. And they were still there for things like, women were like, oh, I'm having this weird bleeding. What do I do? What should I do? And so there were still resources in the community, but there was no formal relationship with them, with the clinic, unless they were also a community health worker. And with the personnel sort of attrition, where newer clinical personnel came in, the community knew who the partera was, but the new personnel, since they had been disconnected from the clinic, did not. And that opened up these spaces where the partera could go to the clinic and not be recognized as a partera, and just be there with the woman as the one person that they can have in the delivery room, helping the woman, even though sort of posing as an aunt or as a cousin or whoever, right? Sort of like a support person, but not disclosing that they are parteras. Now, this is what I saw in the places where I did my research. And I think that there might be other experiences in other parts of Peru, but the work, like the formal relationship between the Ministry of Health and parteras, doesn't really exist anymore formally. That there may be informal arrangements elsewhere, there might be, but I don't think that formally exists.
Yeah, I think it's so fascinating the way the parteras are generating these different roles for themselves as brokers and so on. I mean, they're not giving up. They're not just, they're still.
And I think that this is
communities. Yeah.
This is the lack of understanding from the clinical professions to the parteras is that, and this is something one partera told me, is that for them it's a job. Like for the clinical professions, it's a job. But for parteras, it's a calling. It's a calling to help people. So it's not like you give up a calling, right? Yeah. If you are able to help people, that is what your calling draws you to helping. And so some of them would say, I'm more careful who I help, or in which ways I help, but I can't turn a woman who lands on my doorstep away. How am I going to turn her away?
So one thing I find so fascinating, because as you know, I did research with traditional birth attendants and skilled birth attendants in Indonesia, and it's a different continent, but there are a lot of parallels. I also found the traditional birth attendants in Indonesia, who are known as the dukun, and they very similarly see their role as helping the community, and they're just going to find new ways to do it, regardless of what the global policy is. So I think that's it's encouraging. It's encouraging. They're brave women. It's very wonderful. So did you have any more questions, Erika?
Another one. Do you believe that intercultural birthing policy could work in the US?
I think that the US needs a culturally appropriate birthing policy. And I think that, yes. I mean, I don't know that I would call it intercultural. I think it looks differently, right? So the cultural milieu in the US is different than it is in Latin America. And there's more also history of working of tradition, what we might call traditional birth attendants, and a push for humanization of birth and other things that I think are needed. But yes, I mean, there needs to be, and I think that, I mean, recently, and I'm sort of tangentially familiar with this, but recently the Biden White House put out a whole document that is a blueprint for better forms of birth in the US, specifically because of the high levels of Black maternal deaths in the US. But really the issue there is culturally appropriate birth, right? And it's holding clinics and people accountable for providing a rights-based approach to birth care, and not a risk-based approach to birth care, which many times sort of, as in Peru, sort of glosses over coercive things in favor of let's just reduce the number. And I think that there's a bunch of people that are really great who are very much working from a reproductive justice perspective on moving this agenda. The National Birth Equity Collaborative, which is led by Dr. Joya Creer-Perry, is one of them. Dr. Karen Scott, who has published work with our own anthropology, Dana Ayin Davis. She has a couple of articles with Dana Ayin Davis on Black mothers, has developed a anti-racist sort of health equity lens quality improvement survey and workshop, where her goal is to certify or provide some form of certification that is accepted for hospitals and clinics or clinical systems to be sort of branded as birthing friendly clinics, right? With an anti-racist lens. And all of that helps all of us, There are many other sort of issues. I mean, Latin American immigrant women have different issues, but I mean, trying to rethink the way in which we provide birth care from a reproductive rights perspective and from a reproductive justice perspective really would go a long, long way in the US.
So,
of course, Dobbs makes the recent Supreme Court decision makes things potentially much more difficult.
yeah.
But on the other hand, and this is sort of how we are parsing this in Indiana, on the other hand, if you really are saying that you support women and you support birth, then okay, show me that you do, right? So you're going to close abortion options, then let's do something on birth. And I think that that's the ways that they're thinking about it in this state. Some people, not everybody, of course, but yeah.
It's so nice to hear some positive things happening in the US instead of what we get in the news is only the negative side. So thank you very much for those.
Yeah, and I mean, there's some really wonderful work in California. Of course, California is kind of a nice place to have these kinds of things. So there's lots of recognitions for lots of rights. But there's some really good templates of how woman-centered birth care and culturally appropriate birth care sort of come together to improve birth outcomes. And so I'm hanging my little bit of hope on those things.
Right. Sorry, did you want to go?
Oh, I was gonna say, I guess, given that there are so many different cultures in the US, my question, you kind of already answered it, that do you think birthing centers or places for birth would now have maybe more Western options and traditional options, or ways to try and kind of meld both of them together, if that makes sense?
Yeah, so this is something interesting to think about. Like, so when public health went through the whole, well, we're still in it, but with the whole culturally competency thing, when it first started, everybody was like, yes, everybody needs to be culturally competent. But then when it started to be implemented, it was like, oh, Latinos do this and Asian Americans do this. And so it really became ossified and it became stereotyping and it became like something that, so when we think about birth, if you think about birth from the perspective, and I think this is something that you can bring in from intercultural health, which is the idea of dialogue, the idea of respectful decision-making and shared decision-making, which is embedded in also the perspective of women-centered care that a lot of midwifery in the US sort of has as a model. That doesn't require you to have necessarily specific cultural practices, because those you can talk about honestly and bring up during your care, and you feel comfortable and safe in doing so. And so it's about respecting the birthing person. It's about listening to the birthing person. It's about working with the birthing person to provide the care that they need to come out of this experience as a joy and not as a violent act. And I think that it's if you frame it that way, then we tried not to fall in the same sort of mistake that cultural competence fell into, to create listings of things, right? Because it is such a multicultural society, and because there's such a multiplicity of care, right? And also such an intersection, right? So you can talk about culturally appropriate care for LGBTQ populations and trans people who are birth parents, and a whole gamut of cultural sort of ascriptions. Like you can be fully born in the US, but you could be Amish or Mennonites. And so the idea, I think, is to center the birthing person as a full human with rights, with knowledge, and with decision-making potential. And I think that is what we should do.
Great. Well, I think that sounds like a good note to end our interview discussion. So thank you very much once again. It's been really, I really enjoy, you're very expressive, and you've really brought your article to life. And so I hope everybody found that very engaging, and I certainly learned a great deal. So thank you so much.
Thank you so much to you. It was great. It was great talking
Very
about
much.
this. So.